Welcome, everyone. I'm Dr. Carl Miliazzo from the Shawnee Mission AdventHealth Foundation, and I am chair of the Senior Physician Organization. And today we are so fortunate to have a webinar by Dr. John Freed on the COVID-19 pandemic, past, future, and our experience at AdventHealth Shawnee Mission. I'd like to welcome all the members of our Senior Physician Organization, our Retired Nurses Organization, and Board of Director members who are online with us today. Just a couple of housekeeping measures. First of all, if you're having any trouble at all connecting to this webinar, please jot down this phone number. It's to one of our staff members on the foundation. Her name is Alicia, and her phone number is 816-808-0124. Again, 816-808-0124. And Alicia can help you with any technical issues that you might have with this Zoom presentation. We know this is kind of new for a lot of folks, and there can be glitches that you get disconnected or you can't see the webinar. Just give her a call, or text her actually would be better. And that is a mobile number, and she will try to help you in any way she can. The other important things to know about this webinar is that if you wiggle your mouse a little bit, there'll be some tabs that show up at the bottom of your screen. And if any questions that you happen to arise during the presentation you'd like more information on, there's a Q&A tab on the bottom right. And if you just click on that and type in your question, then that will be presented to Dr. Freed when he's open for questions at the end of his presentation. Also, if you, we're not sure exactly how many people are going to be joining us, so if you hit the chat button and just say hi, we can also know who is online with us today. So to get started, I would like to invite Tim Rogers, who is a member of the executive board from our foundation, to give us a short prayer. Tim?
Would you please bow with me? Heavenly Father, thank you for the opportunity to serve our community. Help us to pause often to reflect on the hard work and sacrifice that so many have shown in the face of something that we had little time to prepare for, and in many ways still have more questions and answers. Help us think clearly. We pray for the families impacted directly and indirectly, even losing family members here and across the country and the world. We pray for our healthcare providers that have sacrificed by putting themselves directly in harm's way in order to care for their fellow human being. Let us continue to look for ways to take care of the people that take care of us. We thank Dr. Freed for sharing his time and expertise today. We pray that he and his family stay safe as he cares for his patients in our community. And we pray for administration and leadership throughout our city that they continue to look for ways to keep us safe. And let us show love for one another in our changed lives as we venture back to normal. In Jesus' name we pray, amen.
Thank you, Tim. There truly has been an outpouring of support from the community for supporting AdventHealth, and the foundation has been extremely busy in accepting donations and gifts to help support our staff in the important work they do. We really, the foundation has really been responsible for all these gifts, and we really want to thank them and all the staff for what they have done to help the needs of the hospital over the past 6 to 8 weeks. And we're especially gratified to work with such a tremendous, talented group of people that have put this webinar on today and have allowed us to become more informed and educated about this pandemic. I'd like to, at this moment, introduce Laurie McCormick, who is the executive director of the foundation, for some opening comments.
Thank you, Carl. You know, Carl's right. There has been just such a great outpouring from the community for this hospital and for all the caregivers. And the foundation team has been honored that we have been the ones that have been in charge of collecting, distributing, stewarding, recognizing all the kinds of generosity the community has put forth for this hospital, whether they were considered tax deductible or not. And some of them are considered things we can count, and some of them are things we can't count, but they count just so much for us and all the work that we can do. So let me give you an idea of what that's looked like so far. We have received $52,600 worth of meals for our caregivers. And that means we've been able to cover caregivers, not just at Shawnee Mission at 75th, but South Overland Park and Lenexa and College and Metcalf and Home Health and some of our other outlying Centra Cares, et cetera. So we really have been distributing that as far as we can. We've received $226,000 worth of other kinds of in-kind gifts, such as PPE, and we received 1,000 units of hand lotion, and we received 800 pounds of gloves, and 76 cases of hand sanitizer from a distillery that changed its business model. And in fact, Sam Hunegart went and picked those up himself. There's also been a lot of generosity that is not countable, that we can't put a monetary value on, but it's been so important to us. For example, we've received 1,200 homemade masks that have made it possible for us to, when things were kind of tough, to be able to mask our patients and some of our workers. At one point, we had workers in the ICU that were really worried about wearing their scrubs home, and they didn't really want to wear them home. And so the team was called on, oh gosh, we got a call on a Saturday morning to see what we could do quickly. And within just a few days, we had 500 plus gently used scrubs to make sure that they could come in their work clothes, their home clothes, change into scrubs, leave the scrubs behind. They'd be laundered overnight and waiting for them the next morning. So it's been really, really busy. Just this week, we had a gentleman who was with a local investment company, and he wanted to support a restaurant. And so he bought 25 gift cards from that restaurant and then gave those gift cards back to the restaurant owner for him to hand out to people. And instead, the restaurant owner contacted us and gave us those 25 gift cards. So we're going to be figuring out how best to use those to benefit some of our caregivers. Some of the generosity we have as a team gone out and sought, and it's been interesting kinds of things that we don't usually do a lot of fundraising for. So for example, when the hospital set up a serenity room for our caregivers so they'd have a place to go and to take 30 minutes and just chill a little bit and be calm and be in a calm environment if it was getting too much. The team here went and solicited tropical trees from Family Tree Nursery, and Costco gave us 0 gravity chairs so that the team members could sit on that. We had a call out that we had patients with COVID-19 coming in, disconnected from their families, and they hadn't brought chargers for their phones. And so that was their only way to connect. So we reached out to a local AT&T store, and they gave us 25 phone chargers and 25 cords. So it's been really interesting, the kinds of things that we've been working on, and a great deal of fun for us. We've been very honored to be able to do this. From a cash perspective, we've also received a lot of generosity from our board, from donors, from foundations. We have over $110,000 in the door so far to support meals, hotel rooms for our caregivers, PPE, all those kinds of things that we need to keep our caregivers safe. We just received word this week of another $25,000 that we requested from the Kansas Health Foundation, and that was to help the hospital in its support of 2 very low-income communities, one in Kansas City, Kansas, and one in just down the road from our 75th Street. And that $25,000 is providing disinfectant, cleaning materials, and food staples for those communities. Also, AdventHealth, our corporate perspective, we have really found out how advantageous it is to be part of a large health system in a time like this. Because as all the hospitals were scrambling for PPE, there was some real advantage to being able to buy very large amounts of it, to the point where it's my understanding that our corporate office actually had to rent out the Amway Center in Orlando so that they would have a large warehouse in which to take all this PPE in and then distribute it out to the various hospitals. There's 50 hospitals in the system, and not all of them enjoy being in a community as large, affluent, and generous as we are in Johnson County. And so we wanted to make sure that all of our caregivers were getting the same kind of support that our foundation is able to provide for our caregivers here. So corporate has set up a central fund for those people who are interested in supporting our caregivers across the system. And that can be reached through our main website. And we've also been doing things like this. The foundation's been working really hard to stay in touch with our constituents and our donors. In terms of, I hope many of you have received the email blogs that have been coming out, the newsletters have been coming out, and we've been trying to keep everyone up to date and informed as to what's happening with the foundation and what's happening with the hospital. Likewise, we also are moving forward. So the foundation team, for the most part, I'm back in the office. You see Lisa and Stephanie are in our conference room, and the rest of the team will be coming in permanently on Monday. Much of the hospital is coming back to life on Monday, and we'll be starting to do some more elective surgeries starting on Monday. So much as the state is starting to open up, we're also opening up in phases, and we're trying to figure out how we can continue to conduct our business. We're in the relationship business, how we can conduct our business with all of the very necessary safety precautions are around safe space and safe processes and procedures. So that's kind of where we are with the foundation, Carl. Thanks for the opportunity to share.
Thank you, Laura. That was great. Now we'd like to move on to the presentation from Dr. Freed. Many of you know Dr. Freed, and he has been affiliated with the AdventHealth Shawnee Mission for over 35 years. As a matter of fact, he and I started at the same time at Shawnee Mission. And he has served in many roles at the hospital as the chairman and of the Infection Control Committee, and he's been an epidemiologist at Shawnee Mission for over 15 years. He's the medical director of the Wound Care Center, and he served as chairman of the Internal Medicine Department. He's been a member of the Medical Executive Committee. Dr. Freed got his medical training at the University of Kansas, and then started there and then finished up with a fellowship in infectious disease also at the University of Kansas. He and his wife Hillary have 3 children, and interestingly, their son Elliot recently joined the staff of Shawnee Mission as an ER physician for AdventHealth. So John's going to speak for about 30 minutes today, and then if you have any questions while his presentation is going on, just click on that button, wiggle your mouse so that the tab comes up at the bottom, look for Q&A and type in your questions, and we'll try to answer as many questions we have in the time allowed. We do plan on promptly ending around 11 o'clock. So John, take it away.
Carl, thank you for those kind words. I'm looking forward to reconnecting with many of my friends and colleagues from over the years. Today, I want to spend about 30 minutes or so talking about the COVID-19 epidemic. It started in the fall in China, moved to Europe, then to the east and west coast of this country. And now today, you can hardly open the newspaper or watch the news without feeling like every story is about COVID-19, whether it's the sports or the business. I guess there's no traffic jams or mass shootings anymore. Even the weatherman is speculating on whether the change in weather will affect the spread of the virus. So what we'll talk about today is the COVID-19 epidemic. I'd like to review with you what I've gleaned from the literature and the news and combine that with my experience with AdventHealth Shawnee Mission, with infection control, with the administration, and with direct care of the patients, and try to put this picture in of the epidemic in a context as we're doing. The epidemic started clearly in the city of Wuhan, China, a town of 8 million people that no one ever heard of. Was it the wet market, where the definition of food is anything that moved? Was it the Wuhan Institute of Virology? Has done some excellent, solid research work with viruses, particularly viruses in bats, coronaviruses, and how viruses move from animals into humans. We don't really know, but somehow this virus, which was similar to a bat virus, infected a human, who then infected another human and another human. And pretty soon we had an epidemic in the Hubei province of China. They actually shut down the whole city of 8 million and locked it off, but it was too late. The germ was out. It moved to Europe, where probably the the key was a soccer game in Milan, Italy. There's a town on the outskirts of Milan, Bergamo, kind of a third-rate soccer team, was having a Cinderella year. They were beating everybody. They made it to the quarterfinals of the Champions League. I mean, this is big time for this little town. The game was so big they had to move it from Bergamo to Milan in order to get a big enough stadium. Bergamo, a town of 110,000, sent 40,000 fans to Milan to watch the game against Valencia, to send about another 5,000. If you're familiar with the European soccer, you know that social distancing is not one of their values. And whenever there's a goal, people scream, hug, jump up and down, kiss. And there was a lot to be happy for. The Bergamo team won 4-1. Of the 40,000 people in the stands, there are probably an equal number in the hometown watching in bars and restaurants, probably just as crazy as in the stands. However, within a week of returning home, the first people in the town of Bergamo became ill with what we now know as COVID-19. Within 2 weeks, the deaths were coming in. At this point, a town of 100,000 has seen 1,000 deaths. It's just taken over and spread from Bergamo to Milan to all of Lombardy in northern Italy. Meanwhile, the opposing team from Valencia in southwest Spain experienced a similar outbreak of COVID-19 that then spread to the Spanish country, then to the rest of Europe, and then to America. And now we have COVID-19. What I would like to talk about today is a few issues. I'd like to talk about some basic virology. I want to talk about some epidemiology as it relates to this pandemic. Then I'd like to relate some of my experiences taking care of patients and working with the administration at AdventHealth Shawnee Mission with infection control and incident command, Dr. Botts, our chief medical officer. And then if there's time, maybe I'll try to speculate about what the future holds. So with no further ado, let me proceed to talk about basic virology, i.e. the corona bug. The coronavirus is called a corona because on the electron microscope, it looks like there's a crown, like a crown of thorns around the virus. If you look at a cartoon of the virus, what we see clearly is you have the central RNA strand in its nuclear protein, a viral envelope, and there are a number of envelope proteins, including what's called the M spike glycoprotein. The way the virus works is that M protein hooks to the ACE receptor, the acetylcholinesterase receptor, the same one that ACE inhibitor drugs hook onto. And it's almost like Velcro with a hook and loop. The virus attaches with the hooks on the spike glycoprotein to the ACE receptors that are on the alveolar cells, and probably to an extent the vascular blood vessel cells as well. The virus hooks to the cell, and then it merges its cell envelope into the cell wall, and the virus is taken inside the cell like almost like an amoeba eating an organism. Inside the cell, the virus RNA unloads and then hijacks the body's natural protein synthesis mechanism with the ribosomes and the Golgi apparatus to create new viral proteins that then assemble into a new virus, which then buds out to spread to other cells. It's doing this very efficiently. The virus is in the pulmonary secretions and are excreted when we cough, when we sneeze, and even on the mucous membranes of our mouth, nose, eyes, and as we touch our face, which we're not supposed to do, on our hands, and then attaches to inanimate objects or fomites. Some basic epidemiology. Epidemiologists talk about the CFR, the case fatality rate. This is a simple concept. It's the number of fatalities, the number of deaths due to a disease, divided by the number of cases diagnosed with that disease. Now, what we really would like to work with is the infection fatality rate. What percent of the people with infection will actually die? Unfortunately, this is a much more difficult number to establish, the number of infections, as that depends in part on The medical system, access to care, abilities of the doctors to actually make a diagnosis, very dependent on the ability of laboratory studies for these viruses to confirm the diagnosis. As you well know, with coronavirus, there's been a large absence of adequate testing supplies. Any doctor will tell you that he has patients calling saying, I think I have the virus, I'm sick, I have fever, I can't breathe, I want the test. You go to the ER through all of March and most of April, unless you had an infiltrate or were hypoxic enough to be in the hospital, they say, I'm sorry, we can't test you, there's not enough tests available, we're saving them for hospital patients. And so they were not really counted as a case because they were not confirmed. One can look at a simple model. If you had 30 people with a disease, one dies. If you're able to diagnose 10 of them, you'd think the case fatality rate is 1 death out of 10 cases, that'd be 10%. But if it really are 30 people with the disease, 20 of which you did not diagnose, the infection fatality rate would be more like 3%. This would be a huge difference in terms of how much effort you're going to do in terms of isolation, close down business, quarantine, in order to try to control the pandemic, if you're looking at 10% versus 3% death rate. Looking at these numbers with the COVID virus specifically, we see that the United States, as of Wednesday, when I made this slide, there were over 59,000 deaths and 1 million diagnosed cases, with a case fatality rate of 5.7%. What's the true infection fatality rate? I would say that if we're lucky, we're diagnosing 10% of the cases, maybe even 5% or less. The world numbers look somewhat similar, 200,000 deaths out of 3 million cases. But even though the case fatality rate is somewhat of a flawed statistic, it is noticeable that you can see some trends. One thing is the case fatality rate is very dependent on the age of the patient. It has a fairly low case fatality rate until you get into your 50s, which case is about 1.5%. And every decade, it seems to increase by 2 or more. So in the 60s, it's 3.6%, 70s, 8%, over 80, 15%. When people say, well, COVID is just like the flu, well, if you look at the case fatality rate for influenza, which is very well worked out, we can definitely see it's not the flu. The other key statistic in epidemiology is what's called R0, R with subscript 0. This refers to the number, a theoretical model, if one person with the disease would enter a susceptible population, how many secondary cases will occur in one cycle before that first person is cured? With the COVID-19 epidemic, it looks like if one person who's infectious enters a population, he will probably infect 2 to 3 people. These people then infect 2 to 3 more people, and you see the exponential spread. By comparison, MERS, Middle East Respiratory Syndrome, was thought to be a potential problem. It has a very high mortality rate, 30 to 50%, but the R0 is very low. It's not highly contagious. As a result, MERS was a little outbreak in the Middle East and never really spread before it was essentially extinguished. Probably the most contagious of the contagious diseases is measles, with an R0 of 16. This is why it's so important that we maintain herd immunity through vaccination. Measles can decimate a susceptible population, a la the American Indians of the 1700s, 1600s, when the Europeans came. Smallpox, also a very dangerous disease, which fortunately has been eradicated through vaccination. If you apply this R0 to the COVID-19 with a R0 of 2, that means if one sailor comes on an aircraft carrier, and before he's resolved, he gives it to 2 more sailors, and then they give it to 2 more each, giving you 4 new cases or 7 total, and they give it to 2 more. Within 3 cycles, you have 15 infections. One can express this mathematically very simply as y equals x squared. Just a simple logarithmic curve. On a logarithmic scale, it becomes very clear this is very linear. The R naught, the basic reproduction number, though, is not a constant like pi or square root of 2. It's a function of how things behave. It's a function of the attack rate, what percent of people who are exposed, and the function of how many people are contacted or there to be attacked. So with the, if one person has an average of 5 contacts and the attack rate is 40%, you'll get an R naught of 2. But you can affect these things. The attack rate depends on the virulence of the virus. If it mutates, it becomes less virulent. Depends on the host factors, like the age of your host, or the older or the younger. Contact depends on how much contact there is. You can control this with quarantine, taking your infected person and putting them in strict quarantine so the contact is 0, giving you an R naught of 40% times 0 or 0. Social distancing will help by reducing the contact. Doing things like washing hands, wearing masks, not touching your face, chuckle, chuckle, chuckle. These reduce the shedding and will reduce the contact and affect the R naught. So the important thing is we can affect R naught by our behaviors, the do's and don'ts of social distancing. Applying the principles of R naught and attack rate to the COVID virus, you see a simple graph of the history of this epidemic, the number of cases going from January to April. We see this looks just like that y equals x squared curve. The death rate in the red line looks smaller, but if you blow it up, so going from 0 to 200,000 instead of 2.5 million, you'll see again, you see a logarithmic curve of the virus going up. Now it does look like there may be some flattening. A true logarithmic curve would go straight up on the right. And it looks like we're beginning to flatten out a little bit. We're able to do some interventions now to try to flatten the curve. You be like Darth Vader. With contact, wear a mask. Don't keep yourself socially isolated, and follow the recommendations of authorities and our leaders. Enough epidemiology. Let's talk about what I do, which is take care of the patients. We're seeing a number of patients coming in with the COVID-19. Unfortunately, their presentation is extremely nonspecific. The classic triad is fever, cough, either wet or dry, and then with more severe cases, shortness of breath. I have seen a number of cases where the primary presentation was initially gastrointestinal, stomach pain, diarrhea, and then they developed pulmonary symptoms. What we're discovering now is that the virus seems to affect the blood vessels in the blood to cause a hypercoagulable state with increased clotting, heart attacks, strokes, pulmonary emboli, thrombi. And in fact, some people, that is their presenting symptom, is a thrombotic event. There's one thing that's kind of unusual in that many people, maybe 20% with COVID-19, reported that in the beginning of their syndrome, they lost taste and smell, which is not unique, but kind of unusual compared to fever, cough, short of breath, which we see all the time. Part of the problem in trying to deal with what's going on in our community is that we are pretty much looking at the most severe cases that requiring hospitalization and the critical cases requiring ICU care. So many cases are mild and not being diagnosed, in part because we don't have the tests or people aren't coming to the hospital. And people who are asymptomatic and don't even present for evaluation, we really don't know how many people like that there are. I suspect that what we're seeing truly is the tip of the iceberg. We're beginning to see a bit of this ratio. We look at closed populations like the experience on the USS Roosevelt aircraft carrier. When they saw a cluster of patients presenting with coronavirus, they proceeded to do a testing of all the sailors aboard the ship. There were almost 4,500 people on an American aircraft carrier. When they tested them, 3,920 were negative, 660 were positive, and 7 of them went to the hospital. So looking at that on this pyramid curve, if there were only 7 in the hospital and 660 were positive, and actually 1 died, may give you an idea for the proportion of mild cases that are not coming to the hospital that are out there, as you focus on the number of diagnosed cases and hospitalized cases. What I mostly am seeing in the hospital are the sickest people. The pattern that we're seeing is they present with cough, fever, shortness of breath. They have significant hypoxia. They proceed to respiratory failure. And we found that respiratory failure with the COVID-19 is a very severe, very frustratingly slow disease. If you're on a ventilator with COVID-19, you'll probably be on the vent for 2 weeks or longer with progressive ARDS. We need to watch for complications of hypercoagulation. We need to watch for secondary infections from prolonged ICU care and ventilator care. And when people do recovery is also not quick. People with severe disease will be feeling really badly with fevers and cough and dyspnea for 4 to 6 weeks or longer until they fully recover. Our experiences at beautiful AdventHealth Shawnee Mission reflects the national experience, but does have some differences as well. AdventHealth has done some statistics. This is a slide which I'm sorry is too busy. Let me just point out a couple of the keys. The total number of cases we've had at Shawnee Mission diagnosed to date is 81. Most of the patients, 95%, come from home. All ages of adult patients, very few children, almost no neonates. This blue line here on the graph of the bars show how many tests we've been able to do. You see that since the beginning in the end of March until this week, we've been able to gradually ramp up the number of tests we're able to do. The total number of positives, the red line, you can see even with more testing, it appears to be flattening and is not going up nearly as fast as our increased testing. Diving down in a little more detail, this shows a graph of how many tests and how many positive we've had at AdventHealth Shawnee Mission since March 15. You notice on the left side, they're all light blue, which are people under investigation, basically tests pending. In the beginning, our test took about a week to get results back. So we would test people and we wouldn't know they're positive until a week later. There around March 25, we started seeing more and more patients. We developed the test around the second week of April that we could turn around in 24 tests in 24 hours. Mod Laboratory, in collaboration with our pathologists, were able to give us access to a test that would pretty much give us results later that day or the next business day. So we saw that we were diagnosing more and had fewer people under investigation. What's interesting when I look at this slide is our peak day was actually April 6th. And since then, there's a clear pattern towards fewer new diagnoses. I think it's important to remember that when you reach the peak, these curves tend to be somewhat symmetrical. So once you're at the peak, you're not done, you're basically halfway done. So we could expect more disease, but the fact that the rates are going down is very encouraging. Our specifics at Shawnee Mission, as of the height of the epidemic, we had about 30 people in the hospital with COVID-19 and 12 people on the ventilator. As of Wednesday, when I made this slide, we were down to only 13 inpatients, 2 on the ventilators, and with the new testing, and now we even have a 2-hour test available, no one is in the hospital simply waiting for results. Looking at this in context of the county, state, and world, Johnson counties have 464 cases, Wyandotte County somewhat more. In the state of Kansas, we're over 4,000, so probably 30% are Johnson and Wyandotte County. In Kansas, we've had 129 deaths as of last Wednesday. Compare this to New York with over 100,000 deaths, or Florida, California, Texas with over 25,000 deaths. Our 129 deaths make you appreciate how bad it is not here in Kansas. This is actually a very good place relative to other parts of the country. There's still counties in Kansas that have not had their first case of coronavirus yet. We were very worried about how this disease would affect us. AdventHealth Shawnee Mission did some modeling. Again, I apologize for the busy slide, but I want to point out this was their model for the expected number of hospitalizations. The green is the actual data, and the blue was the expectation based on this model with R naught and attack rate. They were anticipating a total of 1,200 patients will be diagnosed with coronavirus in our community. It was thought that the number of people needing hospitalization would be 473. The gray line here is how many beds are available at AdventHealth Midwest, which is Shawnee Mission, Ottawa, our new facilities at Metcalf and College Boulevard and 168th and Metcalf. We have a total of 574 available beds. They were anticipating 80% of our beds will be full of coronavirus patients. We'd have maybe 100 beds for everything else. The middle slide looks at just the ICU. The gray line is our capacity at the facilities. The blue line, the green line is what our experience is to date. Blue line was the model's expectation. They were expecting at the height of the epidemic in June, we would need 95 ICU beds, of which we have 74. 21 patients would need an ICU but not have a bed available. Looking just at the ventilator patients, again, on the far left, you have our true experience patients on the vent. This model anticipated that at some point we would have 63 patients on the ventilator. Shawnee Mission, just to let you know, the gray line, we had 20 ventilators available in the hospital. They were able to buy 10 more, so we had 30 ventilators. There were an additional 30 machines which could be used as ventilators. The machine used for anesthesia, some of the temporary ventilators used in the ER, even some of the BiPAP machines could be modified for ventilation for patients that don't have complex ventilatory needs. We had the ability to theoretically have 60 ventilators if we needed them. It's reassuring that so far we've only needed 12 at our worst and 2 this week. So they're expecting worse, and I'm hoping that we've seen the peak and the worst will not happen. Part of the future history, if I can say that, of this epidemic will depend on our ability to treat the disease, to control the disease. Currently, there is no specific treatment for coronavirus for COVID-19. There have been a number of drugs and agents which are being tested and tried. I had on highest authority that Clorox kills the virus, although that's not a recommended treatment. Hydroxychloroquine or chloroquine, the malaria drugs, Plaquenil, the Chinese thought it was extremely helpful in their management of the pandemic in terms of improving survival and shortening the disease. What they published, though, is one very small report of about 30 patients done anecdotally. They say that a full study is coming out but hasn't been published yet. They use azithromycin as a synergistic agent. We're concerned because both chloroquine and azithromycin are associated with prolonged QT intervals in the EKG, which can make you prone to arrhythmias, and these have been seen. Currently, a large study from the VA hospital came out looking at hydroxychloroquine for COVID-19 patients, and what they found was actually, it did not help, but actually increased mortality. Now, I'm a little bit, I'm not ready to take this study as the last word. Because of the backorder and shortage of hydroxychloroquine, we were only using this in the most severe cases. Generally people who are going into respiratory failure, heading toward a ventilator or on a ventilator. Most of our antiviral treatments seem to work best when given early in the course of the disease. Think of Tamiflu. If you don't get your Tamiflu within the first 3 days of influenza, it really shows no benefit. Treating herpes, HIV, early treatment seems to be much more effective. The fact we use the hydroxychloroquine not in the early disease because we didn't have enough, there may be still a role for this in early disease and even in prophylaxis to treat people who are exposed but aren't even sick yet. There's been a lot of excitement about antivirals. One of the beneficial spin-offs of the HIV epidemic is a huge amount of research in antivirals. Lopinavir is an approved HIV drug. It's available. It had a reasonable amount. In vitro, it seems to control the coronavirus. They tried that in people, and it had really no appreciable benefit that could be gleaned at all. There was an antiviral remdesivir. It was developed as an HIV drug, but turned out it didn't really help HIV very much. It was repurposed for the Ebola epidemic and seemed to have some benefit for Ebola. In vitro, in the test tube, this seems to be our most potent antiviral. This week, a big VA study using remdesivir came out and appeared very favorable. The results are modest. I wouldn't get quite as excited as some people are. It reduced the average length of hospitalization from 14 days to 11 days. The change in survival was not statistically significant, but trended towards improvement. The main thing it showed is that antivirals probably will have a role, possibly with different doses, different timing, in synergy with other drugs. It appears that a big part of the disease of COVID-19 isn't the infection, but the immune reaction to the infection, the cytokine storm, the over-exaggerated immune response that actually damages the lungs and creates the ARDS. We have tried using interleukin inhibitors like IL-6. We've used this maybe 4 times at Shawnee Mission. On our small sample, we are not that impressed. Using convalescent serum, number 3 on this list. This is like the old horse serum before we had antibiotics. You take a patient that had COVID-19, survived, has high titer antibodies, you draw their plasma and give that to a patient who's acutely ill. This study is being run out of Mayo Clinic. My colleague, Dr. Samir Desai at Shawnee Mission is our primary investigator at Shawnee Mission. And we've used this treatment about 6 times at Shawnee Mission, convalescent serum. Although the first patient died, the next several looked like they probably had a significant improvement within 3 days of receiving the convalescent serum. This looks like a very promising bridge to help people. The key to treating these patients, though, really is excellent pulmonary care. My praise goes out to our our pulmonologists at Shawnee Mission, Dr. Nelson, Dr. Bowers. I'm blanking. They're really the real frontline people. They're in the room, managing the ventilator, keeping the oxygen level going. What we found is that prone ventilation, putting the patient on their stomach, seems to actually help the oxygenation and helps the VQ mismatch. And it allows us to avoid putting patients on the ventilator. It appears that the positive pressure ventilation may actually be problematic in terms of exacerbating the pulmonary damage. So we're trying now to avoid ventilators as much as possible and try to use them really as a last resort, not as a first resort. There are dozens of additional agents which are being tried or tested, or there's small anecdotal reports. Ivermectin is an antiparasitic drug that seems to affect the uncoating of the virus. High dose IV vitamin C to stabilize the cell membrane to prevent the pulmonary damage has been used. Zinc seems to interfere with a magnesium-dependent uncoating of the virus. One study suggested that smokers actually had a lower incidence of COVID-19 severe infection than non-smokers. And there are some theoretical models that explain how nicotine may actually have an antiviral effect. I don't know if we want to advertise this one too much. Maybe a reason to use nicotine patches. Steroids have been used for severe sepsis since I was a medical student and have generally been unsuccessful in improving morbidity and mortality. They've been used for the cytokine storm in COVID-19 with equally disappointing results and are generally not recommended. Clorox is not recommended. The future, what will happen? When will this virus end? This virus will probably be with us for a long time. I suspect that the pandemic will really shut down when 60% of the population is immune, either through acquiring the infection or being vaccinated with an effective vaccine. Hopefully with these mitigation steps we're taking with social distancing, will help slow down that until we can reach this level of immunity. We can hopefully reach this without overwhelming our hospital capacity. Will there be a second wave as people stop social isolating? Probably yes, but I think we'll be more prepared for the second wave. We'll have our supplies of PPE. Hopefully when this happens, we'll have more data on therapeutics, and we'll be more able to deal with these people. When can we stop this social distancing? Clearly in Kansas, it looks like our peak has come and gone. Governor Kelly in Kansas just yesterday had a press conference announcing the phases for reducing and phasing out the lockdown over the next 1 to 2 months, assuming that each phase is not associated with a significant jump in the incidence. I'm hoping that we'll see things settle down by May and June, and by July we'll maybe be reaching our new normal. Will there be a treatment? I think there will be. Will there be a vaccine? Yes. The World Health Organization publicized that a statement that they're not sure that people are immune to the virus after they recover from it. When I saw that, I said, is there any evidence that they're not immune after recovery? And I haven't seen that. It's just there's no evidence that they are. The old rule in science, the absence of data is not data of absence. In most coronaviruses, there is post-infectious immunity. It's generally not lifetime, but it'll last typically a year or 3. So I would anticipate that after people recover from the virus, there probably will be immunity that will prevent them from getting reinfected, at least for the next few years. However, I think we're going to find that our world will have a pre-COVID-19 phase and a post-COVID-19. I think even when things get back to normal, we're going to find that people are going to be much more hesitant about being in crowds. We may find that bowing may replace handshaking and high-fiving. I think we'll see travel may never go back to the previous levels that it was before. I think we may see face masks, which are already very common in Asia and Japan and China, may become very common. I think we'll see much more online learning and conferencing. So I think normal may not be normal. I think what we're going to see is that we're going to need to modify our everyday behaviors to take care of our new normal. At this point, I think I've talked long enough and left some time for questions. So a parting thought as I entertain any questions which were chatted in.
John, thank you very much. That was excellent. I clicked on Q&A and there doesn't seem to be any questions. I'm going to ask Lisa if they've received any questions for you.
No,
Lisa, are you on board?
Lisa's here and we haven't had any questions
Okay, well, maybe
us either.
I'd like to start out with just talking a little bit about the testing. Early on, there apparently was a fairly high percentage of false negative tests reported with COVID-19. Is that still the case, or have they improved the testing?
There was one study that suggested as many as 70% of the cases were false positive, which meant that the test suggested that false. The test suggested that you were clear, but you really did have the virus. Part of that may have been a function of obtaining the specimen. The original test depended on a high nasopharyngeal swab. You put a small culturette way up the nose. It feels like it's going to come out your ears. You leave it there for 10 seconds. 1, 2. Or I'm having so much fun with this. I mean, it's a painful, difficult test. The oropharyngeal test, the throat swab, was not as effective. The quick up and down nasal test was not as effective. And then we were running out of swabs. So we're using non-specific viral swabs. We were running out of transport media. So we're using saline for transport media. All these things will make the test less sensitive and contribute to the false negatives. There really is not a true gold standard test to compare with. So it's hard to know what the true positives versus the testing positive is. I believe the testing is getting better. In fact, now there's a new test which is reportedly very accurate based just on spit, which is a very easy specimen to get. In fact, at AdventHealth Shawnee Mission, we're starting a project. We're going to do the spit test on every employee and staff member and try to establish what is our actual positive carrier rate here at the hospital. Kind of interesting, in our OB unit, we were testing all the mothers when they came in for their delivery, because if they had COVID-19, we wanted to know, before they got up and exposed everybody. So for the last few weeks, we've been testing every mother coming in to deliver. These are asymptomatic women coming in just to deliver a baby, and 2 out of 63, or about 3%, were positive for COVID-19. So the testing will get better, will get easier. I'm sure the early test, particularly with a difficult specimen collection, probably did have a significant false negative rate.
Great. Thank you. It looks like we do have some questions coming on board here.
There's been reports of some of the dermatologic manifestations, COVID-19 toes. I saw those pictures. I can't say that I've, in my experience, have seen or diagnosed it that way. ACE inhibitors, that's a really interesting question. As I said in that first slide, the M spike protein attaches to the ACE receptor in the lung. Early reports suggested that COVID-19 was much more common, severe disease was much more common in people with mild hypertension, which at first didn't make a whole lot of sense because, hypertension, mild controlled hypertension, is not generally considered an immunosuppressive condition. It was postulated that people on ACE inhibitors and also people on ARBs, it is noted that this causes upregulation of the ACE receptor in the lung. It's like when you try to block the receptor, the body compensates by increasing the number. But people on ACE inhibitors had increased numbers of ACE receptors, and it was thought that might be a reason why they are more prone to severe disease. The cardiology organizations, American College of Cardiologists, have recommended that people stable on ACE inhibitors not stop at this time. They have found that people who acquire severe disease, if you stop the ACE inhibitor after they're infected, they actually do worse. I postulate that maybe the ACE inhibitors, although increasing the number of receptors, may also partially block the receptor and block the virus from binding to the receptor. So once you have the disease, it's clearly too late to stop. In fact, you should not stop. If you don't have the disease, will you improve your chance of avoiding it by stopping ACE inhibitors and ARBs? The powers to be say this is not recommended, although I'm not too sure that's going to be the final answer. So that's a simple question with a complicated answer. I hope that helps.
Good.
Oh, hello, here I am.
There's some other questions there, John.
Okay.
My husband has rheumatoid arthritis and takes methotrexate and a biologic similar to the one that is showing positive results. Is there any evidence that other RA biologic helps as well?
The broad spectrum immunosuppressives like methotrexate and prednisone are not going to be helpful, and in fact probably are immunosuppressive. Some of the monoclonal antibodies that are directed against interleukins may have significant benefit, and those are the ones that we're currently under study. Tamsulosin, again, one of the drugs that's being tested. I don't know if there's any convincing data one way or another on that yet. That certainly is not something that I'm using in my patients.
Good. As a question for Roger there, what did our country do wrong? How much is enough? And when it comes to preparing for an unknown biologic risk?
Well, when you look at that graph, the logarithmic curve, the virus starts slowly and spreads quickly. It was pretty clear in China in January with the amount of spread they had that this was a contagious virus that was going to go through the human population. Given our modern society with extensive traveling, to think that this virus would be limited to China was probably not realistic. In January, there probably was the time to start working on stockpiling PPE, increasing production of PPE, preparing for a surge capacity. New York City, I read, has an average of 1 million international tourists per month. Just looking at the landings at the 3 airports. A city that has 1 million visitors per month, to think that a infectious disease starts in one part of the world and won't get there simply was not a realistic hope. I think we may have been able to do more in January and early February, maybe have contingency plans for earlier quarantine, shutdown, social isolating. We may have been able to catch the disease earlier on that logarithmic curve and cut down the numbers. The virus was going to be here, it was going to affect us, but maybe not have affected us quite as severely and as quickly as it has.
There's another question. Can you see that, John?
Okay. Nanocrystalline silver. So a lot of the metals, silver, copper, are broad spectrum antibiotics, antivirals. Think of Silvadene. So most of these organisms, the metals will disrupt their envelope or their cell wall. So silver, copper, gold are very broad spectrum antibiotics, antivirals. The use of Acticoat, which is a topical bandage with silver, is very good for cleaning up wounds. Whether you can use silver internally at a dose high enough to affect the virus, I would be suspicious. I mean, silver itself is fairly toxic, and so I'm not too sure we're going to be able to reach a therapeutic level of crystalline silver internally. I think that may be kind of like Clorox, maybe good for surfaces, may not be so good internally. Other monoclonal antibodies, are a number of them that are being tested, and at this point, the data is just too young to really comment on it.
Yeah.
Truly, the check is in the mail, whether it's these new monoclonal anti-immune drugs are going to be useful. They're somewhat limited because they're just so darn expensive. But on the other hand, so is 3 weeks on a ventilator. So
Yeah.
that does give us a little wiggle room to work with.
John, I have one final thought. We're getting towards the end of our program here, but interestingly enough, on a report today, there was comments about BCG and oral polio vaccine as possibly being used to stimulate innate immunity. In other words, they've noticed that people who have those vaccines tend to have immunity to other diseases than what they originally were intended for. Do you have any comments about that at all?
You know, trying to stimulate the immune system seems in general a good idea. BCG was a vaccine used to mitigate the severity of tuberculosis. It was used widely in the third world. And it does give prolonged immune stimulation of various parts of the immune system. So it may be helpful. Likewise, polio vaccine, the polio virus and the coronaviruses are very, very different. I mean, they both are RNA based. I'm not too sure if we're going to be able to see a whole lot of difference. Part of the problem would be hard to study because in this country, probably 90% of the people have been vaccinated against polio. So you'll have to find a group that missed their vaccine and see what their incidence is. These are things we'll probably, I mean, you know, we'll do this lecture again next year and I bet I'll have a lot better answers.
Yeah, great. John, thank you so much. You've been wonderful. It's been very, very informative. And I want to thank you for giving this today and taking your time to be with us. and also thank all the participants in this webinar. This is a kind of a first for the foundation in terms of its educational effort, and hopefully we can do something like this again in the future. So thank you, and this ends our presentation for today. Goodbye, everyone. Have a great day and stay safe.